Let's go ahead and get the meeting started.
It's 4:30.
We'll start at 4:35, 4:31, excuse me. And I'll entertain a motion to, we're in open session right now. I'll entertain a motion to approve the agenda as presented.
Dr. Sorrells, I believe there's an agenda item that
Yes,
will be.
we want to take one agenda item. And it is H or?
It is item 11F. That would be tabled to the next meeting.
Yes.
It'll be removed from this agenda.
On the Dr. Pandia's.
Yeah, the reconsideration.
So we won't do it today, we'll go to the next meeting. Any other changes? I'll entertain a motion to approve the agenda or disapprove as presented. Approve as presented. Second. Second. All in favor?
Aye.
Thank you. Let's move on now to the consent agenda. You should have had it in the email. I'll entertain a motion to approve or disapprove the consent agenda. Motion approved. Second. All in favor? Aye. Thank you. You have before you the minutes for September 28th. If you want to take a minute to review those.
There are two corrections
Okay,
for last month's minutes that we all agreed that all members should have face sheet of the liability insurance policy that the board has.
what page is that, Dr. Pandya?
It is not, it does not appear in the minutes. But we did agree that we need to have the face sheet of the board liability insurance policy for all the board members. And it's not mentioned in the minutes.
There's no board action.
Yeah, I don't think there's board action. I think there was the declaration page was going to be provided
Provided in
for both
the summary.
session for the board's review.
No, it was for a copy.
Not voted on by the board, so we should, there's no need to it.
There was a request and there is an agenda item for today's presentation on that agenda item.
And the second item is also does not appear in the minutes is that we did discuss and the board approved that whatever action that the board took for the censor, then it would be reconsidered under the
You
new.
want the minutes, you want it added to the minutes and brought that next week, next month?
No, it should be added to this minutes because it was decided last month.
So
It was decided last month, is reflected in this communication that Mr. Chairman, you sent me. It already reflected in here. The communication that you sent me is already reflected here. That board has adopted a more formal policy as of September 28, 21 meeting. The board granted the request to reconsider the July 27, 2021
Was that on the agenda?
using the new policy.
So
We had on the agenda last month.
it was, so he's looking at item F9. And if you'd like, Dr. Pandya, I can reword that sentence. I believe it was to follow all the new policies that were adopted. So the,
Item F, right?
yeah, item F would be reconsidered
what
using
page is that
the
you're
hearing
talking
to censor, the code of ethics, and the unauthorized disclosure policy.
What page you're talking about in the minutes?
6.
F. It's in F. So,
It's there, no? It's already there, no? You have to reword
No,
it.
under the new policies and procedures. So you said you're going to add that.
I'll do some proposed language and then you guys can vote to approve the minutes or disapprove them at the next meeting.
No, it is basically already here and decided. You see that here. on this page, on the letter that Mrs. Chairman sent me,
Sure, but the more formal policies would include the code of ethics and the unauthorized disclosure of privileged information and the new censor policy. So I've no problem putting that language in there, but I think it should be there for everyone to review.
this is the language.
Well, it's incomplete, isn't it?
No, this is the email that I sent to Ms. Whitney, that it was an omission from the minutes. So that need to be added to the minutes.
It was sent to Whitney yesterday at 11 a.m.
Well, no, I sent it to her over the weekend, but she was not here.
You had one more thing?
So I would
Oh,
prefer
Dr.
to
Penny
provide,
had one other correction too, so this is the first one.
this was the second one.
This is the second
What
one.
was the first one?
First one was about the insurance policy pay sheet, that all members should have that.
Mhm.
That's all, so that we have some evidence of insurance coverage.
All right.
We're going to do it next week. Going to take time to approve the minute that this added to them.
It's up to the board.
The minutes need to be amended and the appropriate language need to be placed into the minutes.
So the language I think that was used was that the reconsideration would follow the new policies, plural. So that's the new ethics and policy, the undisclosed disclosure of privileged information policy, and the censor policy.
So you're proposing to add that?
Okay, I make a
Carried.
motion that we amend this F to reflect that as per the new policy. That's the motion.
The new policy is plural.
Yeah,
correct?
so we change that. With that, we're gonna
Okay.
Do I have
make a
a
motion to
second?
approve the rest of the
Do I have a
minutes.
second to Dr. Fegre's motion?
I'll second that.
We have a second. All in favor?
Aye.
All right. Thanks, everybody. We'll now, any further discussion? We'll now go from open session into closed session. So we'll go from, we'll open session at 5 o'clock. Maybe just a little bit after. do a closed session. We didn't get it all finished due to time. I think the staff report was information only. I will take a recommendation to approve or disapprove the quality of care peer review and credentialing.
I make a motion to approve all of them. I make a motion to approve the both credentials and quality report.
Okay. So we have a motion, or a second, all in favor?
Aye.
All right.
Aye.
Okay, item C was information only. Item D was information only.
And I'd just like the minutes to reflect that Ms. Hefner and Dr. Pandya and Dr.
And
Emi were recused for
absent.
those items.
Hearing C and D. And the rest will be covered after closed session. So now we'll move on to public comments. And do we have anybody that would like to make any public comments?
Secretary, did you receive anything?
No, I didn't.
Was that not a request for information by public? Or they're separate?
That's a separate item.
Okay, public, we're going to business. And the first item on the business, can see that sheet.
This have a, it's the hospital CEO report.
Yes,
Okay, after public comment.
it's not in this.
Oh, it is. Okay. So just a couple things I wanted the board to be aware of. It happened in October. We did have had some leadership changes. We have a new manager of IT, which is Autumn LaPon. She's been here for quite some time. She's been a project manager. She accepted the manager position of IT. The other individual is Jennifer Ragalado. She started on Monday. She's our new director of respiratory. We have had 2 director resignations this month, our director of IT as well as our director of respiratory. So those are some leadership changes. We have brought on a new addition to our leadership team, which is a director of operations. His name is Josue, and he's be working with Diego on the QHC lookalike. So those are leadership changes I wanted the board to be aware of. From the staffing perspective, on October 31st, as you know, we're under state surge hospital order under Dr. Duncan, and we will be having 20 of our travelers leaving us. So we've been very busy. We did get an extension this month. They were supposed to leave us earlier at the end of September, and they gave us an extension through October 31st. So that was good for us. That gave us the time to recruit some other travelers to fill our open positions. So I'm happy to report that our last offer was made to ED night shift. So we've got ED fully staffed. We are good in L&D and our ICU, so we can continue to operate the capacity that we are in ICU, which is our 10 beds, and sometimes a beta unit, a beta ICU, which is a second ICU. Our med-surg still has 2 open positions, and where our biggest need is in the operating room. We've had just an out-migration of circulators, and we have a 4 open circulators. So it's not a pricing issue for us to try to get travelers. It's actually just a supply. We cannot find them. So that's going to be a little bit of a hurt this next month, but we're working pretty hard to try to fill that. On the requirement, which you'll hear an update from Jeff on COVID, but on the requirement for our employees to be mandated vaccination, I know I reported out that our medical staff did very well with the requirement. And as a result of our employees, we only had 2 employees out of our 1,000+ employees that had to put on administrative leave. So all in all, I think we did pretty well. I was very concerned when the mandate came out, but we've done very well. In addition,
I'm sorry for
yes.
interrupting. Well, how many was that again?
Oh, yes. We lost 2 employees out of our 1,046 employees.
Very good.
Yes.
That's really.
They were put on administrative leave. So we did, I felt like we did it. And as a result of the exemption requirement, We are testing Monday through Thursday. That's going very well. And we're using the color system to send our test off to Valencia. So employees are complying with that. We do have an enforcement component to that now. And so that's going well for us as
We
well.
have to do our own machine. It's still not working.
An update, Ron, on our,
I would think any day now, they have to go through the mandated control testing of it, but it's 3 to 4 weeks of that kind of testing. So I would think any day now it should be up.
so all in all, it's been a busy month, but we've done well and so we're looking into November and December and these holiday months. So at the end of this week, we do have approved vaccination for one family member for our employees and our medical staff. So if there's anybody you'd like to bring to employee health to get a flu vaccine, we are also, I believe, offering those in the vaccination clinic as well. The flu vaccine.
Not yet.
Not yet. They will.
We don't have access to them.
Okay, but we are opening that up for if one family member to be brought for every employee for flu vaccine. So, and that's all I have for right now. Thank you, Jen.
Thank you very much. Someone I have a report on. Any questions for Jeff report, Dr. Hudson?
Good evening, everyone. So the story is the same. It's the consistent volume that has been going on now for several weeks. So we average about 40 patients in the hospital every day. It's kind of where we're at. The ICU was at about 80% COVID patients. We're down to about 40% now. So we've seen a drop. I will tell you, we've had a lot of death in the last couple of weeks, especially on several days. Multiple people have succumbed to their illness. So that has been a little discouraging for staff. So we're trying to see what we can do to help keep the resilience up, especially in the critical care area. With that being said, Donna alluded to the vaccine clinic. That is going very well. We have some weeks where we're giving 1,000 injections over 3 days. The city's been very good about giving those incentive programs you've probably heard about. People get $100 if they come in for either a primary or a booster shot. So that is happening again this week. So we've been doing very good there. We will add boosters this week for the Moderna vaccine. That was just approved today by the state of California for us to move forward. So Thursday we'll be prepared to start giving Moderna boosters and only Moderna boosters. We won't be doing primary vaccines. And then we're waiting for the 5 to 11-year-olds to be accepted for Pfizer. That probably will happen the next week, and then we'll begin to give those injections for those kids as well. We've learned that most of the pediatric providers in the area have not sought to get the vaccine in their office. So it looks like they'll be coming to clinics and or the pharmacies. And I don't know how much the pharmacy will want to do 5 to 11-year-olds. That gets a little more risky giving injections to that young population. Monoclonal treatment has been going very well. As of last Friday, we had given 61 patients monoclonal antibodies. Today we did 2, tomorrow we have 6 more coming. So they're really starting to come in. I think people are getting the word and the providers are starting to use it in primary care. We have a couple of providers locally who are using a lot on their patients. So yes, sir.
What were the outcomes of the monoclonal antibody patients?
Well, we've not had any except for one in the last several weeks that had been admitted to the hospital. So it has helped stop the progression.
And they're high-risk patients, right?
They're high-risk patients. They need certain criteria in order to get the Regeneron. Yes. So that has been helpful, hopefully keeping some of them out of the hospital. And then
They were referred by the doctor, right?
yes, they have, the provider has to write an order and then we give it as an infusion clinic. They're here for about 3 hours, an hour to get ready, an hour to give it, and an hour to watch them and they're out the door.
Doing the which center, cancer center?
Nope, we do it up on the 3rd floor.
Yeah.
Yep, we use our COVID unit. We have a couple of rooms up there. We can put 2 or 3 in a room together. We give the antibodies and out the door they go. So, trying to use every bit of real estate and all the nurses that we have to do this. Outside of that, that's sort of how business is going. I'll entertain any questions.
So are you mixing the types of vaccine for booster, Moderna?
Yes, people can
Pfizer?
do that if they wish to, yes.
So you're able to do that?
Yes, yes. So if someone comes in and had J&J and they now want to get boosted, let's say on Moderna, whatever, they can do that. Yes. or Pfizer to Moderna, Moderna to Pfizer. They
Are
can,
we gonna mix them over there now? Can we do mixed?
yes, you can mix over there. Yes.
Just means Moderna is supposed to be lower dose, right? The booster dose is like 50 micrograms or something.
Yes, so you get half a dose of Moderna,
Yeah.
2.5 mils instead of the 5. Or excuse me,
It's a 25.
They have the dose.
yeah, half a dose, 0.25. I said that wrong. Anything else?
Good job.
And the admin numbers are about the same, or is it leveled out?
The
or
admin
do you see it
numbers?
Dropping.
No,
Yeah,
they're level. They've not gone down. They've not gone up. They've been very stable.
it doesn't look like either direction, we don't know, okay.
Nope.
Because we were predicting it would be going down by now, right? Is that what the?
That would always be our hope, right? So we would get to 0, but that is not going to happen in our lifetime with the conditions we have right now. There's so many people not.
And still high
vaccinated.
most of your patients that are doing poorly are unvaccinated people.
We all do have some people who have breakthrough infections who are fully immunized, but usually they have some comorbidities that are
Severe.
adding to the issue.
So we're still with the Delta, right? No Mu and all the other stuff here, right? Only Delta. and-
Only Delta right now, and now we're watching Delta Plus. As the UK is struggling with that right now.
Thank you.
So we can go like Thursday when they're open, and if we have a Pfizer, we can get a Moderna or a J&J.
Yes, just bring your cards with you so we can sign them.
Thanks. Okay, any questions? Further? We had one public records request, and by Kevin Sousa. He's the general counsel for family health care, and he requested any and all public available documents associated with the last 12 months of Board of Directors meeting at Searview Medical Center, 9/2020 through 9/2021. This would include board packet materials related to items on the agenda submitted to board after distribution of the agenda packet. PowerPoint slides if made available to board members and any other documents, materials that are not exempt from public disclosure under state or federal law. So that's the only public records request that we've had. Next, we'll look at our business action items, and we'll look at the audit financial report.
Connecting Los Adams.
We're gonna do it by Zoom.
Yes,
Okay.
they're gonna connect to our.
Hi, this is John from Moss Adams.
John,
Hello. With me is Brian Connor and Justin Gomes.
Say good evening, everyone.
You're gonna see it on the Zoom or not really?
yeah. Are you guys able to share your screen with us?
Right now, we only have rights to talk. We don't have any of the controls that would allow us to share a screen.
Okay.
Okay, how about now?
You can see Brian.
Good
Hi
sign.
there. Yeah, I think that should do the trick. Yeah, we have the ability to share here, so we'll pull it up on the screen here in just a few moments.
Justin, are you on?
Yeah, but I'm still not able to share or.
I will share then.
Thank you.
So Whitney, we need to be able to share and remove your presentation. My stuff out of the way. All right, Brian, can you see the presentation?
I can. Thanks, John.
All right, take it away, sir.
A lot of pictures of the rain we got yesterday.
Right, yeah, that's exactly right. We're, so it's a delight to be here with you this evening to present the 2021 audit results for Sierra View. As was mentioned earlier, myself, John, Senior Manager, and Justin, Senior Manager on the engagements to go through this. So next slide, John, let's get to the agenda just to tee this up. So, what we'd like to do is walk through our audit opinions and reports on the deliverables that we have for you that we expect to issue here very shortly. Some communications with those charged with governance, which we are required to provide the board of directors and the audit committee. And it's also a really good dialogue on the results of the engagement. And then we do have some financial highlights in graphical form of current year financial statement numbers compared to prior year for trending information. So that's what we have prepared for you here today from an auditor opinion and reports perspective. We have audited the annual consolidated financial statements for Sierra View for the year ended June 30th, 2021. And that's what we'll be talking about here over the next several slides. But it's also important to identify for you the non-attest services that we've also provided the organization over the previous year and during the time that we were engaged to be auditors, so that we can assess our independence as auditors. And you can see the 3 bullets here, the additional information or additional services that we've provided or intend to provide for you, including assisting in drafting the consolidated financial statements. We expect to assist in drafting the auditee portion of the data collection form, which will be filed later in conjunction with the single audit. We'll talk about that in a little bit. And we're also assisting the organization in some Medicare cost report appeals. None of these services impair our independence with respect to your annual audit. So we believe that we are in fact independent with respect to that engagement. And of course, our audit opinion on the financial statements is what we are engaged to do. Those financial statements are the product of your management team. So Sierra View really owns the financial statements, and we're responsible for an opinion on that financial statement. And we have a draft unmodified opinion on your financial statement. So it means we believe the consolidated financial statements are presented fairly and in accordance with U.S. Generally accepted accounting principles, generally accepted in the United States of America. And we believe those financial statements are fairly stated. So an unmodified opinion is a classic clean opinion on your financial statements. We're happy to report. We will have other reports related to this year's financial package once the single audit is completed. That single audit is really the compliance work that's done over the provider relief funds. And you have several months to complete that. And there's still a few things that need to occur for us to be able to do that. So there will be additional work related to that grant and some additional reporting related to that. But currently we're happy to report that the work that we do on the financial statement audit, where if there were any findings, would roll into that single audit report. There are no financial findings that will carry over to that single audit report. So again, another really good outcome there. And for areas of audit emphasis, which we had highlighted in the planning session with the audit committee members earlier this summer, I'll turn it over to John to walk through what we did and the results of our audit procedures related to those. John?
Thanks, Brian. So this slide deck shows 6 items that I'm going to discuss. I'm going to actually start with the last one first, the compliance with federal award programs. Brian mentioned that we will be assisting management with the auditee portion of the data collection form, and then there'll also be some additional reports. what that means here is that, we finished the financial statement audit for Sierra View, but we haven't begun the single audit portion, which will encompass those provider relief funds that the organization has received over the past couple of years. As you're well aware, as I'm sure management's been keeping you up to date, the different reporting periods that have been directed by HRSA. And so the reporting period that just ended June 30, 2021 will be that first reporting period that will be subject to single audit. And so shortly after we finish up the financial statement audit, we will be having discussions with Doug and Donna to, get that scheduled, get those procedures scheduled so that we can make sure that we assist the organization in meeting that filing deadline, which is due by March 31st, 2022. So we do have time to make sure that that gets done, but don't want to, let it, creep up on us. And so we'll be having discussions with management to begin that process. Jumping back up to the top of the screen, net patient service revenue. As you can imagine, revenue recognition is always a significant risk area that we would focus on during the audit. Nothing came to our attention during our audit procedures that would have caused us to make a recommendation to management to make adjustments to net patient service revenue. We perform these procedures in conjunction with accounts receivable, where we gain an understanding of management's methodology for estimating the amount of accounts receivable collectible at year end. Through a couple of different means, but primarily through the process of using historical collections on prior year receivables and estimating the current year receivable based on collections made subsequent to year end. And then we take that information and also relate it back into accounts receivables through various procedures of relating it as a percent of accounts receivable and other methods. Third-party settlements with Medicare and Medi-Cal. Management keeps a robust schedule of these settlement and cost reports that are provided every year. We take a look at those, make sure that what they've filed with the state and any tentative and final settlement reports have been properly reflected throughout the year. And then we evaluate management's estimate for any allowances on those settlements and found them to be reasonable. Fair value for investments. So this is one of the areas in your financial statements that are recorded at fair value, unlike, say, capital assets. Management works with its investment advisors to keep their investments at the current market value. Our procedures involve a combination of confirming the existence of these investments with those investment managers and custodians. And then we perform some price tests by sampling the amounts being reported by those investment managers to make sure that they're accurate and consistent with the market overall. And then lastly, the Sierra View District Hospital Foundation. This is a consolidated inside of the financial statements of the organization, and we make sure that management's done a good job with consolidating these statements. This particular entity does have a different year end, and so we pay special attention to the periodic roll forward. They are a December year end, not a June year end like the district itself. Moving on to our communications with this body, this governing body. But before we do that, wanted to refresh your memory on what we're doing and what we do as part of the audit. The financial statements are the responsibility of management, and with your oversight to make sure that they're being fairly presented in all material respects in accordance with US GAAP. We've been engaged as your auditors to evaluate whether or not those statements have been presented properly in accordance with GAAP by performing audit procedures in accordance with both AICPA and then in planning for the audit procedures that will encompass the single audit. We do consider internal control, but we're not going to be expressing an opinion on the effectiveness or provide assurance on internal control. And that if we had found findings, we would be communicating those to you here today. So here's the summary page for these communications. We have completed the audit within the scope and timing that we had set out during our planning meeting and within the engagement letter with management. We have evaluated management's significant accounting policies and found them to be properly stated, reasonable, and in all material respects. Management did adopt GASB Statement 84 and 97. This has to do with fiduciary funds. There are a couple of retirement plans that CRView has at its disposal to offer to its employees. The adoption of 84 and 97 didn't have a material impact because management determined that those two retirement accounts were not, or how should I say this, were not required to be included as a fiduciary fund within the district's financial statements. And so that evaluation is consistent with prior years. There's no change. Had the organization had for example, a defined benefit plan, we would most likely see those financial statements get incorporated at a different presentation level than what traditionally has been, which is just a net liability in the financial statements of similar organizations. Part of our process, as I mentioned, is to get comfortable with significant estimates. One of those large estimates in your financial statements happens to be the valuation on accounts receivable. I've already talked about that one. Our review of the estimates, we found them to be consistently applied and reasonably stated. There are no corrected or uncorrected misstatements that were determined to be, or excuse me, there were no corrected misstatements. There is one uncorrected misstatement. This uncorrected misstatement has to do with some grant expenditures that were expensed in fiscal year 2021. They were actually incurred in fiscal year 2020 and were capitalized as an other receivable in 2020. And upon further evaluation, management has reclassified those as an expense in 2021. We propose that management record those as a prior year expense, which would adjust the beginning net assets of the organization. Being that this amount was not considered to be material to the overall financial statements, management passed on posting these adjustments to beginning equity or beginning net assets, excuse me, and we agreed with their decision. There were no issues discussed with our retention as your auditors, no disagreements with management. We did not identify any material weaknesses during our audit procedures. We're not aware that management engage in any consultations with other accountants, and we're not aware of any instances of fraud or non-compliance with laws and regulations. So before I move on and have Justin kind of go over financial highlights, are there any questions about the discussion as it relates to this slide and those charged with governance?
I have one question. Can you hear me?
Yes.
Okay, so you said there was one uncorrected misstatement of $444,718. What was that about? What kind of expense that was?
So those expenditures, management has had incurred these expenditures in 2020. And upon making application to FEMA to get reimbursed for these expenditures, reclassified or adjusted these expenditures into other receivables. And the proper accounting treatment would have been to leave them in expenses and then evaluate if it was appropriate or not to record a receivable and offsetting grant revenue. And so in 21, having realized that these expenditures should not have been adjusted onto the balance sheet, they expensed these items in 2021, which is it's appropriate to expense them. And then they evaluate as to whether or not they should have recognized revenue for a receivable. And at this point, I don't believe that there was revenue recognized because management is still waiting for FEMA to approve or award this grant.
Okay, thank you.
Certainly. Any other questions? Justin, would you care to go through financial highlights for them?
Yep, sounds good. Thanks, John. So these next few slides here are really just going to be kind of a summary version depicting graphs here, really just showing you kind of a side-by-side comparison of ultimately your financial statements, looking at the prior 2 years, including the current year. So this first slide here is on the asset composition side. Kind of looking across the board, really no unusual fluctuations as it relates to current year to prior year. Everything kind of remained consistent as you'd expect. Really, the only fluctuation I would note here would be a slight uptick in AR with the corresponding decrease in cash and cash equivalents. Really, that increase in AR there is ultimately just driven by patient days or days in accounts receivable, which were up roughly 6 or 7 days, kind of looking at it as a whole. A lot of that is driven first by COVID, the impacts of COVID, and then how that impact has ultimately affected the organization in a sense of longer days that patients are kind of in-house, as well as kind of a little bit harder and a little bit more difficulty getting them discharged, but nothing out of the ordinary there, and kind of everything else really as we would expect to see from the asset side. Liabilities and net position side of things also very, very consistent year over year, kind of normal fluctuations that you would expect to see here. Long-term debt, flat, same with current liabilities, relatively flat. And really the only change in net position is ultimately related to the loss or deficiency in excess of revenues during the current year, but nothing there to note of significance there. Otherwise, kind of all as we would expect it to look like. Moving on to kind of this patient accounts receivable slide here. This is really kind of more to depict kind of where AR is, as well as how that aligns with your AR as a percentage of net revenue. And so I've kind of already noted the increase there in AR as compared to the prior year. Really what's driving the percentage of net revenue there is really just the decrease in revenue as it relates to the prior year. I think revenue was down roughly 5.8 million to the prior year, accounting for the increase in AR is ultimately what's driving that slight increase there as a percentage of net revenue. And as I had mentioned, really all due to the impacts of COVID, the length of stay patients are there and kind of working through some of those obstacles, but otherwise still very well within our expectation and kind of what we've seen kind of across the board and in the industry as a whole. Looking at the statement of revenues here, as I already noted, slight decrease in operating revenues for the year. Looking at expenses as a percentage of those, really relatively flat too as well. The only kind of significant changes, or I wouldn't say necessarily significant, but kind of changes to note, supplies expense had a little bit of an increase as a percent. Really a lot of that is driven COVID expenditures, as well as kind of the organization doing a little bit on the PCI procedures, which ultimately, a little bit more supplies for stents, et cetera, but nothing kind of out of the ordinary or unusual there. And then really the only other big kind of flux or somewhat big flux is really the loss or income from operations there, which is, kind of as you would expect with COVID. The prior year, the COVID impact was relatively minimal, considering about 3 months of that year was impacted by COVID, where as all of FY21, I really kind of saw that full impact and really trying to kind of get up to speed with those impacts. And like I said, very consistent still kind of compared to the prior year and nothing out of the ordinary there. Looking at here some of the ratios we look at, days cash and investment on hand really just measures the organization's ability to sustain operations with existing cash. You'll see higher than normal compared to their previous years, really driven predominantly by the increase in their unrestricted investments in the current year. Wasn't a ton, but the kind of a flux between restricted and unrestricted investments is really what's driving that up. But I think one thing to note here too is you kind of look at the organization for 21, and then looking at that as it relates to kind of Moody's BAA group, as well as kind of other comparable facilities or health systems around that area. You'll see they're well in excess of those, and definitely a very large number there from a days cash on hand, but like I said, still not out of the ordinary for the organization. They typically float around the 400 plus days. So everything there kind of looks as we would expect. Days in accounts receivable, uptick here in the current year, all driven from the same stuff I've noted earlier, which is really just the ability to get bills out the door as well as collecting on those. Really kind of impacted was COVID and how that played that impact on how long it's taken to get patients discharged. Not necessarily out of the ordinary there. I think we've seen an uptick across the industry as a whole. I think there's just been, you know, a little bit longer that AR sitting on the books, but nothing unusual and so kind of as we would expect. And the last slide here is debt to cap ratio remained very flat kind of compared to the prior 2 years and identical to the prior year in general. And that's really just due to not a ton going on as far as a lot of movement in debt. The organization did refund of one of their bonds in the current year, but that refunding and that debt that was issued was ultimately just to refund existing debt for roughly the exact same amount. So really not going to drive any flux in debt to cap, as well as net position remained relatively flat. So we would expect this to also remain flat. And looking at this, you know, a lot lower than the BAA group, just 1% lower than the comp group, which really just kind of shows the leverage of the organization and the amount of debt they have versus their net position. So everything there looks as we would expect. And so that's all that I have from kind of financial highlights. If there's any questions, feel free to fire away. If not, I'll turn it back to John.
Thanks, Justin. You know, I think in wrapping up, if there's no questions, I would just like to thank Doug and Merle and their team for, you know, all of their hard work in preparing for the audit. You know, this is our second year auditing remote. We learned a lot when we were in a remote audit environment when we first entered this into you know, last year for fiscal year 2020. Management has continued to steam forward and make sure that they're prepared for us to begin the audit. You know, the proposed adjustment is just that, it's a proposed adjustment. Management did pass on it, we're fine with that, but I think the more important aspect here is that, you know, there were no audit adjustments. You know, the financial statements that we were provided at the beginning of the audit, there were no adjustments to those financial statements. So the you know, what that means for you as the governing body is that management is producing financial statements for your business decision making process. And you know, from our perspective, those statements can be relied upon to make those business decisions because they're materially stated in all respects in accordance with GAAP. Brian, any wrap-up comments from you?
I don't have any comments to add. It's a good summary, John, and we just maybe turn it over to the board for any questions that they may have.
Dr. Bill?
No questions.
Dr. Secretary?
No questions.
No. Okay, thank you. Very good.
Thank
Good
you.
job, as usual.
Thank you
Thank
very
you very
much.
much.
Thank
Yeah,
you.
have a good rest of your meeting. Everyone take care.
Thank you.
Bye.
Thank you.
I know.
Bye-bye.
Take care. Okay, next we'll have our 2021 September financial. By Mr. Dixon, the chief auditor.
Today, yes, I'm not looking very much like Doug today, am I? But on the bright side, he's trained me well, so I'm going to pitch it financials. So, thank you. Good to go. All right, so first up is our statistics. As you can see here in our September acute care days, actual was actually up comparative 23,000 or 2,300 over the 1,900 budgeted. So where we wanted to note here to the board was the length of stay. COVID has caused some challenges with length of stay, so we're well up over 5. And so where our goal is around 3.9. We've seen it as low as 3.8. And when we're trying to reach those targets, driving that percentage of length of stay down is very challenging. So Melissa and I have actually done some work exploring how we can try to impact length of stay. We've got some outliers that we do on a daily basis, but I know we've got a lot of work to do around this length of stay because this has a financial impact to the organization significantly. Long-term days, we are under budget. This is a one that Jeff's driving every day. We have a 35 bed subacute unit that we need to keep fully staffed and show the patients on a waiting list. We have been keeping 1 bed open as a requirement by CDPH. So we have been trying to keep it up to 34 of the 35 beds fully. So outpatient visits always slightly under this budget. And then you can see year to date since July, acute care days up, length of stay up, and long-term days down. So outpatient visits are up over budget. Year over year, actually more visits, acute care days over fiscal year 19, you see that, and length of stay slightly up. So next item is our September revenues, our total patient revenues, 59 million over the 54 million budgeted. Our total operating revenue, you can see 357,000 over the budget. So total operating revenue is 14 million over the budgeted 12 million. So how that equates out to expenses, operating expenses, salary and wages, total wages, 6 million versus the 6.8 million. Pro fees are up over budgeted, 44%. Purchase services are up as well. Supplies are up, and that brings us to an operating actual surplus of 537,000. As you know, we budgeted a negative budget of a loss of 345,000. So we are showing a surplus and an operating margin of 3.8% for a year to date, or excuse me, for September. And then our other non-operating expenses, as you can see here, there's our non-operating revenues, non-operating expenses, interest expense. And then our net position is in surplus, 690,000 over the budgeted loss of 74,000. So year-to-date revenues, year-to-date, we have a total operating revenue of 39 million, budgeted 35 million, so a variance of 3.1 million, 9%. We keep moving on. On year-to-date expenses, we have a total actual surplus of 767,000 over the $1.7 million loss that we had budgeted. So we are on the upside with a operating margin of 2%, which has been our goal prior to COVID. We were trying to reach a 2%. So at the end of the year, we would have that money to actually reinvest in our capital. And that's how we've been funding our capital year after year. So year-to-date non-operating expenses, there's our non-operating revenue, slightly up over budget, non-operating expenses, slightly down, which is a good thing. And then our interest expense is right on par with budgeted. And then we have a increase, actually our surplus is 1.2 million over the $900,000 loss budgeted. And then year-to-date over prior year, I think really comes down to fiscal year, we were at a $1.9 million loss through this time, whereas we're at a 767,000 surplus. Now, what we're concerned here is looking at year to date, it's around staffing costs. So as we mentioned, being under the state surge hospital order, some of those costs that we've had to staffing have been bared by the state. So these traveling costs are very, very expensive. We're paying rates that we haven't ever paid for, that I've seen in this organization ever before. So contracted staffing costs are definitely an impact to us. And then so you can see salary and wages and the variance there. And then provider fees, actual provider fees, 3.1 million over the budget, 3.2, slightly down. And then provider professional fees, 3.1, actual fiscal year 21 was 2.9, so slightly up there. And then interest rate impact. So your interest income is 453,000, slightly down comparative to last year. And then key ratios. Doug always mentions about how we have our requirement to meet our bond covenants. And so days cash on hand, as you heard from the auditors, is strong. Cash to debt percentage is 299 over the A rating 156. Operating margin 2%. So we're a lot stronger than we were last year at this time. Our EBITDA margin 10.2, and debt to capital 22%, and the debt service coverage, our actual is 2.43, and we're required to have, so much better position than we were last year this time. So, any questions? Thank you. No, just kidding. Just kidding, I'll take questions.
Donna, a part of the staffing cost was provided by the state,
Yes,
and percentage wise, like how much did they contribute
we
year
are.
to date?
We kind of have an idea, but we actually were talking about that this morning. Our financial planning division is actually calculating the actual cost that they helped us with. So I'll bring that back to you. But yeah, right now I'd be just kind of given a best estimate. So I would like to say, I'd like to bring that back.
Is it sustainable? Can we sustain these high rates over how much time until it starts really hitting us?
I know, it's gonna hit over the next couple of months, so if volume stay up, you know, obviously these rates that we're paying, we have 20 of those travelers leaving, like as I mentioned Sunday, and we backfilled those positions where we could, so recruitment wise.
How about recruitment? I was gonna ask that the next
So,
question.
yeah, I know.
Recruitment and retention. Recruitment and retention, right? Huh?
We've only recruited about a third of what we have.
How about retention, keeping who we have?
We've seen a lot of.
Anything like bonuses or any kind of like sign-ons or anything like that to keep them? Because I think people are still trying to.
Yes, they're still trying to self-demobilize. That's the word of 2021,
Right.
self-demobilization that I learned.
Right.
Yeah, it is a thing. And now it's coming with no resignation time. Like, you
Right.
don't get 2 weeks anymore. So yes, retention is a goal of ours, and we've got a lot of initiatives and strategy you're gonna hear about
Okay.
later.
All right.
But I can tell you, we did have a mix or a mingler right in September. And it was our first time it was just kind of like, come join us. It was a Disney theme. And we actually got some applicants, some nursing, registered nurses with experience. So that came, as well as, you know, some of your, we got a hired one that you referred to us, and some of our best hires have been referrals from other employees and providers. So retention and recruitment are the top initiatives for this year. You're exactly right.
Because they're costing so much, and those nurses are too expensive, right? We can't keep paying those
Yes.
fees, right?
So we extended today, it's in 8-week increments, but we have what they call an advanced, extended advanced float pool, not float pool. It's extended the enhanced 48-hour. Oh, excuse me, that is the right terminology. The 48-hour club, which is rewarding our employees that will sign up for those additional shifts like pre-scheduled. So that's helping, and we've been doing that 8-week blocks of time.
Because it's kind of right. It's kind of weird, the morale, you kind of see the morale. I mean, you're a staff member, you're making half as much as a nurse working right next to you, and you're training that nurse. So you're kind of feel what's going to happen with that over time. You're kind of worried, right?
Yes, it's excited, and we're also just grateful for the help because
Right.
they've been working short staffed and.
Are you seeing a lot of nurses taking on?
Stress and-
I'm sorry for interrupting. You're seeing a lot of people taking these extra shifts and stuff and working a little bit more, or is that happening?
The
Okay.
incentive programs that we have in place, we have 3 different incentive programs in place. And they have covered quite a few shifts. I think from 2020, I'm going off the top of my head, I did not take our report last month, but it was a cost savings of about $500,000 from traveler costs just by our own staff picking up those extra shifts. And I think they
That's
picked up
smart.
around 178, maybe 178 extra shifts
Right.
that would have been either unfilled or filled at the higher traveler rate.
Right.
So not only do we have the cost savings, but we have the continuity of care, so that we have our
Smart.
staff taking care, and knowing our policies and procedures.
But you got housing costs and all kinds of other stuff that comes with the travelers as well, right?
Well,
That's
sure,
on
that's
top of
built
it.
into the cost. Yeah.
Right. All right. Thank you.
Thank you. Yeah.
We don't have to pay it back, right, to the state or so far?
Good question.
Are we talking about bonuses yet? I mean, like as far as like retention bonuses, has that been? Am I opening up a can of worms? or what?
No, Monday, we talked about it Monday. Tracy and I, yes, we're doing the creative thinking phase of how can we offer retention.
I think we're coming into that era, right? That
Yes.
time when we have to start thinking of that kind of stuff to they stay.
Yes, so we are actually running some formulas now. So
Thank you.
you're welcome. No, it's great ideas. I appreciate
All right.
it. I think we're thinking alike.
We applied for the latest stimulus, whatever that little funds are.
Yes, last week Doug put in the 4th provider relief fund application, so we are in. So we'll look, we actually also applied, Dr. Reddy, there's a component, we're not rural designated, but if our patients come from rural zip codes, there's some opportunity to gain some funds from a rural, so they're gonna run all of our patients based on where they reside, and if they come to that rural area, we might get some rural
A lot of
dollars.
rural, I think.
Yeah, so I'm hoping we'll see something. We'll give you,
Is that an automatic or you have to apply for it?
we had to apply for it. Yeah, it's not automatic. Yeah.
I have one more. Okay, so I've been reading some articles on why people are leaving. And
Yes.
one of the things is mental health,
Uh-huh.
not addressing the mental health part. And you were talking about earlier about people that that we keep seeing loss after loss after loss.
Yes.
What are we doing to address those?
Yeah. So we just opened our town hall care of the caregiver and the RISE program, which is the, oh my gosh, I had a stressful environment, yes. So we definitely got some initiatives that we're trying to put out to staff as well, as far as those support. And then we do an employee communication every Wednesday of support for just truly for employees. We can send that to you, just so you can see some of the resources that we offer.
I just reading a lot of articles about it, and I think people, if we don't address it, I think that's one of the reasons I think some of the people are leaving as well, because they're just overwhelmed, right?
I read that horse therapy is now going to be some of that post-traumatic stress syndrome is going to be a therapy that is very interventional.
Okay.
Yeah, I don't know how we incorporate that. But it is-
Animals too might be good on
Equine therapy is something that they're using to treat the post-traumatic stress.
Oh, good.
I don't know how that would.
One of the other things that we just started this year, we've had pet partners for quite a few years, and they are there to support the patient. But now we actually have them stopping in all the.
Helping the staff, right?
It's open for the staff as well.
Right.
So that's one of the other things we've incorporated this year.
Yeah.
Don't they have the bovine?
Yeah, I don't know.
I
I vote for bovine therapy on every week.
Little puppy's good. That'll help. Go
I
count nuts
can help with that, Dr.
Thank you.
Thank you. All right.
Any further questions? Let's take a minute. I'll entertain a motion to approve or disapprove the September 2021 financial report by Ms. Hefner. We'll do the financials. Do I have a second?
Second.
All in favor? Thank you. Next, we'll have a resolution on item C under business action items
Yes, I'll
to
turn-
establish the graduate medical education infrastructure training program.
yes, I'd like Jeff to report out on this, what this resolution, why it's being brought back to you. It was passed by the board. I'm going to let you give an update on that.
Yeah, so this was passed a couple of years ago, if you remember back when we were formulating the GME committee or program. This particular document is reviewed by ACGME as part of our institutional review survey we had a couple months ago. And there was one area that they wanted added, not anything that needed to be distracted or they found to be problematic with the resolution, was to add that second paragraph. It is an encompassing statement that the board is aware of the board responsibilities around finances and all the other things that go with GME. So that was the only thing that was added to this resolution. And that'll meet the requirements of the institutional survey that we had just a couple months ago. So you've already signed the initial one. This is actually just readopting a brand new resolution. Questions?
I have a question. Although you are able to and you're quite capable of managing that, but the last paragraph on this resolution makes you the program director for the internal medicine program.
Mm.
And it just, here, I have it here if you want to see it.
I want you to have it so I can.
I think it's just the wordsmithing that some maybe comma or something. Probably it means that the medical director is a physician and not.
I'm willing to wordsmith this, but again, this was approved previously without comment, but to me, it's very clear. It is designating the program director, which is the physician, is the designated authority and accountability for the operation of the program, which is the internal medicine program in this case.
Right, it says
I'm
that-
responsible for the institutional responsibility of the program.
Right, no, I understand and
Yeah.
I appreciate that. Here it says you're responsible for all the ACGME accredited GME programs and the program director.
That's the
It sa-
medical
it's-
doctor.
It says that you are the program director.
No. That I'm responsible for that program director. I'm not the program director.
Can we kind of make it clear, so you can say the period and then have a new sentence, the program director will be appointed by the.
We could do that.
I think that way it doesn't mix, it's kind of confusing.
That is language that's.
Yeah, you can put
distressing.
period.
Make it easy.
Yeah, and just say remove that and the program director, which will be obviously MD, designated with authority, be appointed as CEO.
Correct.
Without having naming, because it could change any day, program director. Yeah.
Makes
sense? That's why I think it's confusion comes, like you're responsible for the program, it's like getting old, right?
Yes.
Yeah.
Will that person change? Could be.
Yeah,
Could we put this in, or we have to change the name each time, or should we leave it physician?
No, we would want to leave it vague, because if you notice there, I have programs there. So if we add any additional community programs, we want to leave it with the program director so that they can be interchangeable. Otherwise, it'd be coming back to every time I make a programmatic change.
Right.
And I'd rather not do that.
Understand.
So that takes, by changing that to a period, it takes that oversight of the program director. It makes it sound like you don't have oversight of that program director with that change. So who has oversight of the program director?
Okay, oversight of the program implies the whole thing, so it includes director and the whole program.
I think we put the period after.
Once you say program, and so it includes, that itself means that the program includes program director.
Okay.
Yeah.
But who has oversight of the program director?
The institutional officer.
Officer, yeah, so it says that.
I have a
in the
responsibility.
Programs, it includes not just that director,
Okay.
any future directors.
I think that.
And any
Yeah,
programs.
okay, I get it.
Programs, period.
Okay.
Yeah, I'm responsible for the whole program. whether it's a
Programs.
position or
Programs
not.
And a future programs, right?
That
Okay.
doesn't mean that I'm responsible for the physician portion of GE.
Exactly.
Okay.
But they report up to me.
And,
Right,
Yeah.
they work with you. I mean.
yeah, they were,
Good.
And the only
That'd be
thing,
fine. We find that change. Whitney, can you make that change?
So period after programs, capitalize the, and we're good.
and the only question I would have is if this has already been established, we're just amending the prior resolution, should there be a reference to the prior?
It's actually, we're redoing a whole new resolution. So ever how you want to do that legally?
But since it hasn't already been established, or is it?
We already established, we added a paragraph to it. So it's really bringing the whole thing
the
back. to the
last
body.
paragraph is added basically.
This is not an amendment then, for the first one?
Can
That's basically defining the.
we say that it replaces the prior resolution?
Yeah, that's what I was.
Can we say that this replaces the prior resolution number this and
Uh-huh. Yeah,
So instead of
Yeah,
putting a full stop over there and starting like a P capital, it could be in brackets right over here. The
Okay.
program director, the position designated as the authority and accountability for the operation of the program.
so put the program director in brackets.
Right, right, start the bracket over there and up to this program, because he's responsible for all that.
Right.
But that
Oh, I
is-
see what you're saying. Yeah. Okay.
Does this
Definition of the
supersede the
program
first one?
director, that's all it is.
Yeah.
replace?
it replaces or supersedes, yeah. And I just, yeah, I think having a sentence in there.
It supersedes a prior agreement.
Yeah.
Yeah,
Because there's an additional
So,
whereas added to it.
That's in here, I think.
Yeah, everything's the same and I've added the new language. It's that second paragraph.
So we want to carry the first one up.
No, it'll still stay in perpetuity because you guys signed that when we first started the program.
Basically,
But it was a baby, a thought in the mind.
Not in the mind.
So it was not even a program.
Yeah,
then.
You guys have done a good job.
Could people get mixed up between the
okay,
two?
Me and the program director.
No, if they read the first one, then they read this one.
So I think we're just adding clarity to it, I think.
Yeah, I think the sentence would just be, whereas the board wishes this resolution to supersede resolution, and then we'll put in the task number.
so basically, if I make ACGM requires, in addition to program director, another officer on top that reports to, you report to ACGM, who reports to ACGM?
I do.
So that's what it is. You are basically
Program
between the
director.
program director and ACGME
Correct.
communicating and overseeing. You're
Correct.
like an oversight of, yeah.
Think of me as the administrator.
Yeah, that's where it's kind of responsible means it's like an oversight. Right?
Yes.
That's how I interpret it.
Ultimate oversight.
Of the programs, not one. Yeah,
Yes.
it's more than.
and Dr. Bello suggests where it says the program director, put leave that the program director and put brackets after director and the physician designated with the authority and accountability for the operation of
Will
the
be
program
appointed
with
by
a
the-
bracket. And then, so that we said, originally, the program director will be appointed by a CRVs.
By the CEO, it says,
Yes,
not him, CEO appoints.
yes,
That's what clear.
yes.
Our program directors in future, another program will do,
Now, I
another,
bring the candidate to her, but she
yeah,
approves the,
exactly. Or you kind of recommend.
put him in the role. That way there's a bifurcated, so I'm not.
Okay. I mean, as long as it conveys the meaning,
There.
complies with ACGME requirements, right?
And
Always.
I mean, it's new
And
to us.
the-
So
and
next program will be just.
CMS and ACG, you have to equal.
Are we going to work on any of the programs?
That's it.
Any other programs in the works and? Are we working on any other programs?
I'm in the infancy of working through something right now. Yes,
Okay.
yes. There's more on the pipeline.
Okay.
All right, so you guys have the language that you'll give to Whitney and then
Yeah,
we'll
he's
we'll
got
get the chairman to
complete
sign.
language.
Show it to Dr. Pandya, he had some concern on that.
Yes. Just try to understand it. Well, it has to
Yeah.
convey what we mean, you know?
Better sense of it. See if everybody's on board for that or not. You want to vote on it now or wait and see the change?
Necessary.
No.
This-
Not yet, sorry.
We'll describe it, so you still think it's.
How the program director describes it.
That's okay.
Okay, describing program director responsibilities here.
Well, so I'll read this. Will be, Dr. Hudson will be the designated institutional officer responsible for all of the ACGME accredited GME programs, period.
Yeah,
The program director, the physician designated with the authority and accountability for the operation of the program will be appointed by CRV Medical Center's Chief Executive Officer.
period. Yeah. That's all. I don't think it will be anything different.
So that looks good.
That's good. I don't think you need any more pattern, nothing. You just leave it like that. Just put a period and remove the end.
Yeah, so then I think that we don't.
Encompass it.
into
You're on the
brackets,
top, you're saying subheadings.
Into brackets.
Oh, you use commas instead?
Yeah, you know, just put a
Yeah,
period,
it's into bracket.
down period and capital, the program director. Or any directors, it'll be future more director than one. Yeah, or you can say right now one program.
So that would be the only thing, using commas instead of brackets. Okay.
So I make a motion that we,
Period there and then.
as amended,
Take away the and. Yeah, no, that'd be fine.
That's right, take the end away.
end of it.
Yeah, you have to take the end of it.
I mean, it has also to be acceptable to ACGME, how we write it.
Yeah.
I think they'll be open to that.
Yeah, they'll.
I'll have to,
So,
Dr. Pandya, I'll take the stamp.
so before, prior,
No, no,
we didn't have that
they're
option.
all crazy
They'll be
people.
fine.
The previous resolution did not have that officer.
They have all kinds of need.
Have it.
Oh, it did have.
Yeah, just like
No, I don't
that.
think they'll have any
Yeah,
problem
it
with
was
that.
second paragraph.
Oh, okay, program director that, okay.
Yeah, that was all the same.
I got it.
Yeah.
Fine.
We just improved it. We did.
Good.
So do we all have to sign it or the chairman can sign it?
Just the chair.
Just the chair.
Chair.
Chairman can sign it.
Okay.
So we can,
Everybody satisfied?
We make a motion that chairman sign it.
Please, God.
As He'll be the credit of the first program. Install in the first program.
Your name's gonna be on it. It's gonna be Ken Sorrells.
So we had a motion by Dr. Segretti to
Approve this and.
approve it as amended and written. Do we have a second?
I'll second that.
Have a second? All in favor?
aye.
Next.
So that
Go on.
takes care of that.
Next agenda item, Chairman, we request that be tabled to next meeting.
Which one?
The D.
D, the next resolution, we ask that be tabled to next meeting.
The one on,
The line of credit.
yes, I've got 2 or 3 different page 4s.
Oh, goodness.
It's interesting.
Yes.
Anyway,
Yeah.
so the resolution on the grant we just did, we're gonna table the one on the credit
Yes,
for the summer. The next
next month.
month. Okay.
Then
And the next one.
clear angel. Yeah. Right way.
Next, we'll have the tree of angels report.
Yes, so it's that time of year. And so in your packet is a letter on behalf of the Tree and Angel Committee asking for the board's support. Last year, we found that adopting 75 families, which was a reduction of previous years, was a nice number. And we asked for the board's support of $10,000 donation for this initiative, this goodwill. A partnership that we do with Family Crisis and a lot of our community business owners as well. And Tracy Canales is the executive sponsor on this program and leads this program.
I agree.
I make a motion.
The motion.
Approve the
I
10,000.
make a motion to approve the.
Make a motion to approve the
I want to do it.
Motion. Second,
I'll second it.
all in favor?
Aye.
Thank you.
Next.
The
That's one.
consideration of censure of Mr. Pandia will be tabled next month in November. And if there's no further business, we will adjourn open session at about 6:28. The next directors meetings at November 23rd. We'll take about a 10-minute break and then go back in the closed session. And there's 3 board members, or in front of you is a sheet that we signed before we came out with some new regulations on the etiquette and the way the board and everybody should be. So we need to re-sign that sheet of paper. Here on the code of ethics and conduct for elected and appointed officials. So now that everybody's read it, we need to have her name, printed signature and date. Turn them back in for me and I'll make sure that we get them to the proper people. So the meeting is adjourned.
For 10 minutes.
Hello.
For 10 minutes, right?
10 minutes.
Yeah.